Hello and welcome. Thank you for joining us today for our roundtable discussion on the utilization of COVID-19 therapeutics in the long-term care setting. My name is London Manor-Peterson, Manager for the Community Immunizations team at Comagin Health. Before we get started, I wanted to take a few moments to go over some housekeeping items. If you could go to the next slide, please. We have hosted this discussion today in the Zoom meeting format, which means attendees are welcome to join us by turning their cameras on, and you can also bring yourselves off of mute to ask a question to our panel. We do ask that you hold your questions until the moderated question and answer portion towards the end of today's session, and a reminder to please keep yourselves on mute unless you are speaking to reduce any background noise. If you're calling in, you can dial *6 to bring yourself off of mute. You can also ask your questions through the chat feature. We have chat monitors who can bring those questions forward for you during the question and answer portion of the presentation. We are recording today's session, and the recording link and supporting resources will be shared as soon as they are available. Now, with that part out of the way, I have the honor of introducing our wonderful panel of experts who have joined us for this roundtable discussion on COVID-19 therapeutics. In the interest of time, I will keep their introductions brief. Our facilitator for today's discussion is Dr. Thuan Ong, an internist and geriatrician at the University of Washington, who is also a clinical director here at Comagin Health. Dr. Ricky Trussell is Director of Bengal Pharmacies at Idaho State University's College of Pharmacy. Dr. Jason Rusk is a consultant pharmacist for Providence Marionwood and Providence Mount St. Vincent. Dr. Seth Cohen is Director of Infection Prevention and Control at University of Washington Medical Center. Dr. Megan Dunay, Medical Director of the Idaho State Veterans Home, Medical Director of Keystone Health, and Associate Medical Director of Keystone Hospice. Lilia, I'm going to mess up your last name. I even asked you about Zanova, and Administrator, and Anise Babai, Director of Nursing, both at Klein Gallen Nursing Home in Seattle, and David Trong, a PharmD candidate. And with that, Dr. Ong, I will now turn things over to you.
Thank you so much, London, for that introduction. Can I just do a sound check that I'm good? Beautiful. Thank you very much. I want to thank the panelists again for agreeing to participate in this, and I wanted to thank the audience as well for attending this as well. And so without further ado, we will go ahead and continue because we do have a lot of questions to cover. And like London said, if you can hold your questions or type your questions into the chat, any questions that may come up, we appreciate those questions. Very good. So the first question that we have goes to Dr. Seth Cohen. So Dr. Cohen, could you tell us what are the current outpatient therapeutics for COVID-19? And in your opinion, how effective are these current treatments for COVID-19? And then lastly, what kind of decision tree do you use to determine which therapeutics that you should prescribe?
Sure, thank you for having me. And if my slide is available, feel free to bring that up. Yeah, so this is just a simplified table from the NIH guidelines, which some of you may have seen. The link is in the bottom right corner there, and highly encourage you to play around with that and look at that document. But there are basically 3 antivirals that we use for outpatient management of COVID, and you can see that they're listed in order of preference there. So that's the bottom square. So in order of preference would be Paxlovid. So it's nirmatrelvir boosted with ritonavir. Second line would be remdesivir. And then third line, which is a little more controversial, is something called molnupiravir. And, to answer your question about efficacy, I'd say it's controversial. So Paxlovid is no question, it's the go-to antiviral for our outpatients. It has very, very high efficacy. It's been shown to reduce hospitalization and death when given to high risk folks. The challenge is, a lot of the trials were done in people who are unvaccinated or did not have pre-existing immunity. And so it's really hard to extrapolate from the effectiveness of those trials to the population that this audience sees every day. So, and that, part of that is because the vaccines have just done an incredible job at decreasing death in most patients. So in general, we still think Paxlovid is good, and there is some data on giving Paxlovid to higher risk vaccinated or people who have hybrid immunity. But I'd say the same thing goes with remdesivir. Remdesivir in the trial, it had an 87% relative reduction of hospitalization and death, which is incredible. But these are all folks who had never had COVID or were unvaccinated. So it's hard to extrapolate from that. The challenge with remdesivir is it's 3 days of IV therapy, which is really challenging to do for most outpatients. And then lastly, there's something called molnupiravir. And I would say this is, significantly less effective than the other two. I have only prescribed it a handful of times, and there are really some significant drawbacks that we can get into. But I will say that there are some experts who just don't prescribe it at all.
Thank you very much for that, Seth. Could you share with the audience, how does Paxlovid work and how does molnupiravir work?
Yeah, so these are both, direct antivirals. So Paxlovid is a protease inhibitor, and it's boosted with a drug called ritonavir, which is also a weak protease inhibitor. Some of you may recall that drug being used in people living with HIV, but it basically just boosts serum levels of nirmatrelvir, and it allows it to be dosed twice a day. And the challenge with that is ritonavir has a lot of drug-drug interactions. And so it's really essential before you're prescribing it to make sure that you're reviewing somebody's medication list. And there's some really great websites. One of them is the Liverpool Interaction Checker, which I use essentially anytime I prescribe that medication. And then molnupiravir is a ribonucleoside antiviral. It basically causes a lot of mutations in the virus and leads it to break down. And that's sort of, good and bad. A rapidly mutating virus generally is just going to sort of, go away and disappear in the body. But there's a theoretical risk that, the drug could somehow be metabolized by the human cell. It could lead to changes with DNA. There are concerns within pregnancy and people who are trying to conceive. So that mechanism of action is really important to remember when you're counseling patients around that drug.
Thank you. The next question that we have, Seth, is that who is eligible to receive these COVID therapeutics?
Yeah, so just keep in mind, it's really only people who are meeting high risk criteria that are eligible. And I know it's tempting to sort of expand those criteria, but Paxlovid is still under EUA. And so I hew pretty closely to that EUA. So for Paxlovid, it's people who have a GFR greater than 30, have symptoms within 5 days, and have no strong drug-drug interactions. And there are a lot of minor drug-drug interactions that you can often overcome, especially since it's a short course of therapy. So you can usually find a way around it. But that's usually how I think about Paxlovid. Remdesivir, the biggest barrier is you need IV access and to be able to treat somebody for 3 days. Symptom onset has to be within 7 days. So remdesivir has a little bit longer window than the 5-day window for Paxlovid and molnupiravir. And for molnupiravir, again, it's within 5 days, but contraindicated in people with pregnancy. We don't use it in people under the age of 18. And then again, there's this label that if somebody is trying to conceive, they really should be using birth control, a highly effective method of contraception we recommend usually at least 3 months from the time of receiving molnupiravir.
Thank you for that. And then just for the audience, when Seth used EUA, it's an emergency use authorization. So, and I think this is a great segue to our next question is for Dr. Megan Dene. Could you share your experience with remdesivir use in a skilled nursing facility? I think that you had a really successful experience with using that within a nursing home. And then could you also share your experience with the current available oral therapeutics in terms of its effectiveness and side effects in your skilled nursing facility population?
Absolutely. Thanks so much for asking. I have the privilege of working at the Idaho State Veterans Home in Boise, which is a large, about 124 bed facility with a pretty high occupancy rate over the past several years. And unfortunately, back in October and November of 2020, so the autumn of 2020, prior to vaccination, right, prior to vaccines and as Dr. Cohen was saying, sort of before most people had had COVID, we sustained a large scale outbreak, like many of you all did in the facilities where you work. And, you know, this happened October 31st, actually was our first sort of case. And it was right after remdesivir received the FDA EUA or sort of preliminary approval. And I'm going to misspeak on that. So experts definitely correct me in the chat. But we essentially had enough sort of logistical and formal approval to utilize remdesivir. But that was the only thing we had. People were, you know, throwing the kitchen sink at folks at that time, everything from, you know, high dose dexamethasone to, you know, famotidine to, you know, aspirin, apixaban. It was that era. And so we're sitting here, you know, October, November of 2020, watching this happen in our, you know, skilled nursing residents, these frail, multi-morbid, you know, older adults, and just thinking, oh my gosh, what can we do? So obviously containment is the emergency. We utilized our, you know, resources in terms of, you know, best practices around containment strategies and infection control and prevention. But just as a clinician, as I'm sure all of you guys felt, talk about moral injury, feeling like there was nothing we could do. And so what we ended up doing actually was forging a team. I partnered with my friend who is an infectious disease pharmacist at the Boise VA hospital. And she had the harebrained idea to get the pharmacy to let her package remdesivir in these elastomeric self-infusion devices so that I could then work with my nursing staff and drop them in folks and administer this in our setting. So we, you know, talked to the IRB, got, you know, approval through the Boise VA, and we did it. So we had a scale, you know, 54 patients ultimately over the, you know, 60-day period of this outbreak for whom we gave remdesivir. And if you'll go back to that prior slide, sorry about that. With the remdesivir at that time, you know, we didn't know what to expect in this population. This was an outside of hospital administration of this drug that had an EUA, right? And so we were being extremely cautious. We were following daily labs. I was examining each patient receiving this, each resident receiving this daily. We were utilizing supportive hydration, acetaminophen, loperamide, et cetera. And the results that we found were pretty staggering. So next slide, please. We saw of those 54 patients in our outbreak, 39 ended up receiving any dose of remdesivir. Of those 34, so about 75% lived and 5 died. So what we did find importantly was completion of a 5-day course, a full 5 days of remdesivir, conferred an odds ratio of survival of 16.9. So almost a 17-fold increase in survival in our nursing home residents who received a full course of remdesivir. You know, interestingly, most patients were asymptomatic at the time of diagnosis because we were doing rapid and large scale testing, surveillance testing, and sort of, you know, population level testing, because we were fortunate to have access to those resources. And I know that's something we'll talk about later, is testing cadence, but that mattered a great deal too. So we were looking at 22 patients who were symptomatic at diagnosis, and 14 patients with symptoms at diagnosis did receive remdesivir. 71% of those survived. The reason that matters is because we were able to give these medications extremely quickly, right? So we didn't have to wait until these frail, older, multi-morbid adults develop severe symptoms or even mild to moderate symptoms, because we were testing so frequently. And that sort of points to that last bullet there, is that the mean days from diagnosis to remdesivir was a statistically significant predictor of survival. And so the earlier we could get the dose in to these folks, the first dose of remdesivir, the higher the odds of survival. So it was pretty neat. This is stuff that has been, you know, borne out in the influenza literature, right, with use of oseltamivir in the past. And so it wasn't necessarily surprising, but, you know, we were incredibly pleased to not only try to help these residents survive this infection, but also to learn that, you know, outpatient, so non-hospital administration of IV remdesivir was plausible, especially in a skilled nursing facility, that it did confer a survival advantage, especially when a 5-day course was completed, and that more sort of rapid administration was beneficial. So that was our experience with that.
That is simply amazing. And I, from personal experience, just trying to get this into our skilled nursing facilities here locally has been an incredible challenge. And so the fact that you pull that off is simply amazing. Just a couple of things, since we're on this topic, and you had mentioned it already, Dr. Dene, the times that you have been able to had success with testing and starting COVID therapeutics, what's led to that success?
You know, this sounds super corny, but it's an engaged team. You know, it's a collaborative culture. In our facility, right, 124 beds, and we're only at about 70 to 90 residents over the past couple of years. We have a full-time infection preventionist. We have 3 full-time RN unit managers. We have 3 full-time social workers. We have a fabulous director of nursing. We have a wonderful, engaged, you know, administrator. We had fabulous health information technology who kept track of all of this. So it takes a team. And I know that's corny, but it also takes, and in this case, and as you guys all know, a huge amount of data management, right? So just understanding who's ill, when they fell ill, what type of test data you actually have on them and what that means, you know, days to recovery, sort of physically and logistically where they are in the physical plant, right? So, you know, the complexity of information management honestly was the largest barrier to getting this done at the beginning of this. And on the flip side of that, the thing that has helped us achieve success in just creating a process where it's automatic, where we prescribe Paxlovid unless, you know, like somebody tests positive, the prescription for Paxlovid is sent by me or one of my partners, right? We have an entire team that literally somebody drives to the pharmacy to get the Paxlovid. You know, the pharmacist at our facility knows to bubble pack it. Like we have a whole process, like, you know, step 1, like, do they meet the criteria? Step 2, somebody review all the medications for interactions using that Liverpool checker, right? Step 3, somebody figure out, the DNS is in charge of where the heck Paxlovid is in our city. And then we would send the social workers to get in their cars and drive and get it. So our process is ridiculous, and it takes a ton of people, but it's a team.
Yeah, so thank you so much for that answer. And I definitely respect that team aspect. And so I think that this is a great transition to our next question that is posed. And part of this is that the focus of this talk is about COVID therapeutics, but as you had alluded to, Megan, is you have to be able to test. And so that testing is critical to making that diagnosis, and that time is critical too. So this next question is to Lilia and Anais, who are the administrators and also the director of nursing within a nursing home within the Seattle area. So what are your current parameters around COVID testing for employees and staff? And then what are your parameters now for COVID testing for residents?
Sure, I can explain about that. I can start with what was our parameters before the state emergency declaration, actually.
Oh, perfect.
It was twice PCR per week for the patients, and also twice for staff. And also we had, it was different. That was our surveillance testing, and also within outbreak. Of course, we have been communicating with public health, and they were guiding us in that for the number of testing that we have been doing for the week. And also we have been doing it for acute symptoms of COVID. If it was rising, we have been doing the antigen rapid test, and it was followed by a PCR test to confirm that. But after the emergency declaration ended, we actually switched to twice antigen rapid testing for residents, and 1 time per week PCR testing for staff, which is right now we are doing it. And again, for the within the outbreak, we communicate with public health, and we get their guidance as well.
Thank you for that. And then what Dr. Dene had alluded to, that it takes a team to implement COVID-19 therapeutics. Could you share what your current policies and procedures that you have in place within your nursing home regarding COVID-19 therapeutics?
Sure. Thank you, Dr. Ong. And I have to say, Dr. Ong and his extensions, the nurse practitioners were here with us on the front line when we were going through being in the midst of this pandemic. We had several outbreaks. We were one of the first facilities that used the MAP treatment in the nursing home. And that was quite a traumatic experience, but it actually ended up to be a successful experience for us. I think we gave 9 treatments, and all 9 residents went well, except for one person who had an allergic reaction. But ever since then, of course, nowadays, we're using Paxlovid majorly. For almost 90% of our positive COVID patients receive Paxlovid these days. And we kind of mastered this protocol by it's going very smoothly now. We're very fortunate to have it available through our pharmacy. The protocol really involves, like you said, it's a team. So the providers are on board with the latest standards of treatment. The pharmacist is very much involved. The nurses are very well aware that we need to have labs available right away. Or within the last 6 months for GFR values. And so the minute we have somebody tested positive, we use a lot of antigen testing, like Anise mentioned. If anybody is symptomatic or it was a surveillance positive test, we notify the physician, get an order, send the information about this particular patient with their lab results to the pharmacist. The pharmacist reviews, sends recommendations back to us. We order medication. We most of the time started on day 1 or 2. Of course, the doctors and the pharmacists review the symptoms. Not everyone is recommended to have it, but as I said, about 90% of our residents have some kind of a immunosuppressed condition that they are recommended to. So, and of course, we get a consent from the family and the residents. So we did have some families that are very much against it and didn't want to try this medication. There is also, of course, a concern about the rebound that's being noticed, quite a lot of cases, but not with our residents. We actually don't see a lot of rebound here with our population, which is interesting. And then if GFR values are not favorable for this resident, we used molnupiravir. I can't even say that. Right. We used that as an alternative treatment, probably in about 2 or 3 cases so far, and within the last 6 months, I would say. And we did not see any significant side effects to report. So that's pretty much kind of a.
Thank you. Yeah. There's a chat that is forming, and so Andrea had mentioned that not all long-term care residents and patients have a recent GFR, and Dr. Cohen had responded to that as well. Is that it's also true of many of our outpatients as well, and so in general, prescribing the full dose until you know that you have CKD, but also just particularly because many of us are going through flu right now as well, and knowing their GFR and having the most recent GFR on file is very helpful for the prophylaxis or treatment doses of Tamiflu as well. And so just having the most recent one that you have on file is very helpful. And Rana had mentioned that wondering if the staff should be tested twice as they're facing outside environment and having an increased chance to get exposed versus just once. Lilia, Anisa, did you want to answer that, or did you want me to try to answer that?
I think we're going very much by the transmission rates in the community and in the facility. We did have an outbreak, let's say about 2-3 weeks ago. We had several, more cases than we would like to see. And that's the time we did it twice a week. And we go between having 1 PCR and 1 antigen test, whatever supplies we have available at the time, or logically available. And then now that it's quieting down, our community transmission rate is substantial at this time. Our cases are dying down, and we're still technically in 28 days of outbreak, post-outbreak as public health looks at it. And we feel that once a week with ability to test every time somebody experiences symptoms or feels like they've been exposed, we always have antigen available. And some of our people do get tested twice a week, but majorly it's once a week for the staff right now.
Thank you for that. And then testing is so important, and having the supplies available is so important. How did you partner with your lab to ensure that you had an adequate supply and a timely supply?
That's a great question. I think we can write a book about that. But I think during the pandemic, we ended up with quite a system, and I realized that not everyone has the same system to, we're utilizing the resources, but we are really partnering with University of Washington lab, and we're hoping they're going to keep us on their load for a little longer. But it's been an amazing opportunity for us to really stay safe, because we, at the same time, we do buy our own medium and our own supplies from either McKesson, or we used to get it from public health, wherever we can get that from, we make sure we have those supplies on hand. And we have stocked up on that and been using our own supplies. We have a person who is actually, she's a nursing assistant who we trained to just do that. That's what she does. She makes sure everybody gets tested as many times as we decided we're going to test people. She goes around and collects the tests. We have testing stations. I think Dr. Ong has used some of them throughout the building. This person goes around, picks them up. We have somebody delivering them, hand delivering every single day for the last 2.5 years to University of Washington lab. At some point, we realized we cannot rely on anybody come and pick it up for us. We want to be consistent, and that's really was part of our success. We have a person that just drives the samples to UW lab every evening. They're processed. These days, we get them early in the morning. We got the requisitions. I mean, it's a system that's in place, and this one person handles all the samples, and by early morning we have results been sent to her email. She notifies everyone. We prevent these people coming to work if they are being tested positive. I think about 60% of the time is people that have no idea they have COVID, and preventing them from coming to work or isolating them before the symptoms start, whether it's residents or staff, has been a big deal for us.
Thank you so much for sharing that. It resonates with the story that Megan had shared, how the social worker drives to the pharmacy that picks up the medicines, senior acts. So,
right. And of course, the other antigen testing has been a big part of all of this. And we've been fortunate enough that we continue to get free Binax tests from the government. And that has been very consistent. I think now we're getting them every other week. There was a little, of course, break where we would get whatever we could, but we also are very mindful on being, very thrifty about those, and we try to save for the rainy day when something happens in the manufacturing of this tests. So we do have a stock, and making sure that we have enough if the time comes when it's a low supply.
Excellent. Yes. We're all concerned about supply chain issues, yes, nowadays. I'm going to transition to Dr. Rusk here, is that once a person is diagnosed with COVID, how long is the turnaround time to deliver medications into a skilled nursing facility in your area?
Sure. So speaking mostly to the oral therapeutics, so to the Paxlovid and molnupiravir, once they're diagnosed, once the pharmacy's received an order, they tend to be uncomplicated to dispense. We did discuss the drug-drug interactions that are screened for Paxlovid, but we're generally looking at a same-day turnaround time to be able to get these packaged and sent back out to the facility. Our particular facilities receive drug shipments twice daily on weekdays, once daily on weekends. Our pharmacy does stock these therapeutics, so the turnaround time is quick. Where it can slow down is they don't come from our regular wholesaler, which would be the situation for most pharmacies. We have to set up a separate ordering portal with the state. That can be a delay in ordering. So if your pharmacy does happen to run out of their stock, they didn't catch an auto replenishment point, it may take them a few days to actually replenish it. As long as the pharmacy's on top of that, though, you won't see that. So they should be able to come out fairly quickly.
Thank you for that. And then what are some common drug side effects associated with these COVID therapeutics?
Sure. So I've got a slide put together on that one. Fortunately, these therapeutics have not had a lot of side effects noted. This is, again, looking specifically at Paxlovid and then at molnupiravir. Paxlovid, so what you have here on stage left is what's in the fact sheet, the EUA fact sheet, which is kind of the prescribing information stand-in for a drug under emergency use authorization. So they mentioned altered taste, 6% in the treatment versus less than 1% placebo. Diarrhea, 3% treatment versus 2% placebo. Hypertension, 1% treatment versus less than 1% placebo. And then muscle pain, myalgia, again, 1% treatment versus less than 1% placebo. So fairly mild, similar rates to placebo, except for the altered taste. I did think it was interesting to point out that they did call out people who discontinued treatment due to adverse reactions. And it was actually a lower percentage in the treatment group that discontinued as opposed to the placebo group. So we had 2% in the treatment group discontinued due to ADR, 4% of people taking placebo discontinued due to adverse effects. On the right side of the slide here, post-authorization experience, which is what they would call their post-marketing surveillance in an EUA drug. There have been cases of anaphylaxis and other hypersensitivity. They did point out the risk of toxic epidermal necrolysis or Stevens-Johnson syndrome because that's previously been reported with ritonavir. It has not been reported, to my knowledge, with Paxlovid, but there's the risk since it does contain ritonavir as the booster. And then abdominal pain, nausea, and malaise have both been reported with unknown incidence rates. But again, fairly mild overall, nothing too terribly alarming has come out at this point. And then on the next slide, I've got the molnupiravir. I've been throwing in, they're trying to get it, branded and approved as well. So I'm trying to stick with them and use their branded name as well, which is, I think it's Lagevrio. I'm pronouncing it as a soft G. Diarrhea, nausea, dizziness, really common adverse effects. And as you see, their rates are the same as placebo in this case. So we haven't seen a lot of ADRs there. Post-authorization, they did mention the same risk of hypersensitivity, anaphylaxis, angioedema, however, rates not specified, and then some erythema rash or urticaria as well. Again, unspecified rates for those.
Excellent. And then the next question that we have, and I think that we had alluded to this already, are there renal or hepatic impairment considerations associated with these COVID therapeutics?
Yes, there is. If you advance to the next slide, I like to do all my thinking by slide, so I've got those all set up here. Paxlovid, we were discussing, and it came up in the chat. So the eGFR for renal dosing is important. It does modify the dose in Paxlovid. And when we're looking at our long-term care population, an eGFR between 30 and 60 is not uncommon. So whenever we can get recent renal function, it's it's worth having, in my opinion. We don't have a hard cutoff for how old that lab should be, but we do make efforts to keep everybody who, allows lab draws to have recent labs, especially when we're talking in the, like you said, the fall. We're looking at Tamiflu prophylaxis as well. So we like to have fresh labs when we can. When the eGFR is below 30, Paxlovid is not recommended. As Dr. Cohen alluded to, these are EUA drugs, so we don't have a lot of off-label privilege with them. So we do consider that a fairly hard cutoff as well. If the GFR is below 30, we will look at other treatments. Hepatic, there is a warning to, it's not recommended in severe hepatic impairment, which they defined as Child-Pugh Class C. The molnupiravir or Lagevrio, no adjustment required. They did have a note that it was not evaluated when eGFR is less than 30. However, based on the pharmacokinetics and how they're understood, they don't think that end-stage renal disease or dialysis will have any effect on the exposure. And with hepatic impairment, they also don't specify any adjustments. So Lagevrio, when Paxlovid gets ruled out, there are generally no restrictions for renal or hepatic dosing for the molnupiravir.
Thank you very much for that, Jason. My next question that I have here goes to Dr. Ricky Trussell. What are some common drug that should be either stopped that's associated with using Paxlovid and molnupiravir? And when can they be resumed?
Yeah, actually, let me introduce David for a moment. David's a student who's working with me on rotations, and he put together the presentation. I thought this would be a fantastic opportunity. So I'm going to have David field the questions, and then if there's something he feels like he needs me to jump in on, he'll let me know. If
that's perfect. Thank you so much.
Thank you.
So hi, everyone. My name is David. So thank you for having me. So when it comes to medications that are commonly seen, on one of my slides I had with the Bengal Pharmacy on top of it, it shows like a lot of different medications. And as Dr. Cohen and Dr. Rusk, a lot of other people have mentioned with the Liverpool website with the interactions, you're able to see a lot of different medications that may have contraindications as well as times that you would have to either delay the medication, such as like simvastatin, clopidogrel. There's a whole list of interactions with the whole Liverpool website, and they have really good information about when you need to either hold the medication before starting Paxlovid or any other antivirals, but mostly we see with Paxlovid is medications will be stopped about 2 or 3 days before starting therapy, and then resuming medication about 5 days, anywhere from 3 to 5 days, but preferably 5 days afterwards. So usually I would recommend just using the Liverpool website, either the app, and it's also available on the App Store for Android, both Android and Apple as well. Those are common ones that you can look into and see from there. But a lot of cardiovascular as well as renal and oncology medications that you would see that would have a interaction that would either have to be stopped or held for a moment while on the medication or on the therapy.
Thank you very, very much for that, David. The next question that I have goes to Dr. Seth Cohen. Is it recommended to start Paxlovid on someone who's not getting better from COVID-19, but they're outside of the 5-day window?
That's a good question. Short answer is no. Most people move very quickly from the viral, sort of active viral replication stage to a stage where symptoms are mostly driven by immune response. And the drugs don't work very well for that second stage. And that EUA that we keep referring to generally does not permit that. So unless it's somebody who is highly immunosuppressed, like a stem cell transplant recipient, without drug-drug interactions, I probably wouldn't extend that window.
Got it. Thank you for that. And then we kind of alluded to some of this earlier when Lilia was talking about the rebound effect. Could you just share with the audience what is the rebound effect that she was talking about? And so that's question number one. And then also some patients have shared that their symptoms have returned, but indicating the rebound. But what are the implications of this?
Yeah, it's a really interesting question. So, rebound is, many of you have probably heard about it in the news. There are a number of notable figures and public who have had rebound where, you start taking Paxlovid, you feel better. And then at some point in the next week, days, some point, symptoms come back. We don't really know what the incidence is. I think a lot of people sort of estimate that it's probably about a 10% rebound across the board, but probably really depends on the population. And really interestingly, there's probably a rebound that happens even in people who don't take Paxlovid. So it's not necessarily specific to Paxlovid. Even people who aren't treated can get a rebound. We don't know a lot about what that means for therapy. Right now, we are not routinely giving, and the EUA does not allow us to give Paxlovid if you have a rebound in symptoms. And it may not mean that there's active viral replication, but I would say from an infection prevention perspective, we do restart the clock on isolation precautions for people who develop rebound symptoms.
So if I heard you correctly, then you restart the clock as soon as they exhibit those symptoms again.
That's right. Yeah.
So is it recommended to retest these patients after, let's say, 2-3 days after they tested negative, or only if they exhibit symptoms?
Yeah, I'd say only if they exhibit symptoms. And then, we mostly use a time and symptom-based duration of precautions. So we take them out after 5 days if they're in the general public, and after 10 days if they're in our medical facility.
Yeah, and so it's really based upon the symptomology, it sounds like.
Yep.
Thank you very, very much. And the next question that we have goes to Dr. Dene. And so you kind of alluded to this already by sharing your experience with having a social worker go to a pharmacy to pick up medications, which I'm sure is not within their scope of practice, which is amazing. But what kind of logistic or cultural barriers have you experienced with COVID-19 therapeutics in your practice setting and community? Could you share with the audience?
Yeah, great question. And I should also add that the DNS herself has driven, and as has the administrator and the deputy administrator. So
that's amazing.
Yeah, it's pretty touching, actually. So I think logistically, right, this issue of getting distribution of these medications to long-term care pharmacies, I think that was a big barrier in the beginning of the use of these, oral therapeutics. And in my practice setting, that still remains to be the case. And so we're literally having to, prescribe these utilizing commercial pharmacies. And so that's suboptimal. I should say, though, I live in Boise, Idaho, and I'm in the Treasure Valley of Idaho, which is the population center, right, of the entire state. And so you step much outside of this spot, and logistically, you're in either a rural county or literally frontier designations. And so I think Marcia Whitty was on here, but she works for the Department of Health and Welfare in the state of Idaho, internal medicine physician in palliative care, and just wonderful. But she was sort of she's been the hands and feet of all of this and the brain of distribution of these medications. So she would certainly, I'm sure, have something to add to that with respect to the logistics. But from my experience, it has required a lot of creativity and a lot of sort of courage to be like, okay, I'm going to get onto the COVID, tracker, the COVID therapeutics tracker, like Google where the heck we are, put in my zip code and try to find the thing, see who's like closest to it. I mean, it's been a real scene. But yeah, Marcia, if you're still on here, I'm sure you would have more information.
And I'm just going to give a pause to see if Marcia is still on. I don't have the full participant list.
Yeah, I am. Thanks. I'm kind of been on dueling webinars, so I'm not sure I heard the whole discussion. But yeah, so and actually the other webinar is the national call about therapeutics. But I think at this point, the oral antivirals are fairly well distributed throughout the state. We've really worked now with the smaller pharmacies. The large chains they can order directly through the federal government, so we don't work with them as closely anymore. I did reach out to a number of long-term care pharmacies to see if they wanted to stock the oral antivirals themselves, and did get some takers for that. So unfortunately, as far as finding where they're located, I think, Dr. Dene is right. You just have to get on that locator and put in your zip code and figure it out. But once if it's there, then, we're able to keep pharmacies stocked without any problem. There's been no shortage. So hopefully they're fairly broadly distributed now, and folks have access to them. And if anybody on the call has a long-term care pharmacy that they think would benefit from stocking those medications, we certainly can help with that. So I'll put my email in the chat, and anybody can feel free to contact me.
Thank you so much, Marcia, for that and your work for the state of Idaho. And so distribution and supply is part of it. And kind of like what Lilia had alluded to, and all of the clinicians that are on this call, is that there's definitely some COVID-19 denial in some of our communities and in our patients. And this question goes to Dr. Dene, just because of where you practice, is what is your approach and your language when you care for a patient or work with families that come from a community that distrusts anything COVID-19 related? And has it been any easier with COVID therapy now?
That is such a good question. I have been stunned by the sort of acceptance and acquiescence among the residents, so the veteran population that we serve in our home in Boise. I've been very surprised. I've found in work in assisted livings, it's been a little more hit or miss throughout the Treasure Valley of Idaho, but specifically in the SNF population, I've been stunned at sort of the rates of acceptance. And I do wonder how much of that is sort of this like pluralism and sort of like sort of paternalism of the VA system and sort of like this, just agreement with the plan of care. So it's been very unexpected. What is more common, unfortunately, so the residents themselves have been very, supportive. What's more common, unfortunately, is recalcitrance and resistance from families, as you said there. And so those are difficult conversations, right? And just sort of honing in on the 4 M's of geriatrics, right? Like what matters, and talking about medications and talking about all that stuff, and treating it more as like a goals of care conversation. Because, in the beginning of the pandemic, right, when we had no therapeutics, we had no, vaccinations, we had very rudimentary understanding of PPE, whether this was, droplet or aerosolized or whatnot, very basic containment strategies. The bioethics of non-acceptance or non-acquiescence with treatments were very different than they are now. And so that was a time where we were much more, I would say forceful and directive, and just in terms of setting boundaries about what could and couldn't be acceptable in our setting. But now it's much more nuanced, right? And it's much more, goals of care conversation, honestly, is how I approach it, and just sort of understanding the 4M framework really of like a, age-friendly health system or age-friendly care episode of care, because without sort of an understanding of a patient's goals of care, you're shooting in the dark. So that's not a very good answer, but it's been tough, and it's iterative, and every wave brings something new, every, new bit of misinformation, every, overblown, vaccine reaction. So it's navigating constantly, and it's hard.
Yeah, I think that for those of you who are on the call might not be familiar with the realm of geriatrics, where the 4 M's, and one of the M's stands for what matters most. And so having that kind of what matters most to that individual, and what you talked about, it's an iterative process, that constantly reapproaching it and just giving people the opportunity to have a change of heart, or maybe a change of their way of thinking. Thank you for that. Yes, it is very hard. Thank you for sharing that. And thank you for continuing to do that as well. So Lilia and Anise, the next question goes to you. So how do you view the impact of the use of COVID-19 therapeutics impacting your residents' perceived quality of life, thinking about the 4 M's, for example?
I think this has been, and you know, we don't know exactly what is really making a big difference. I think it's a combination of things, of course, having almost 100% of our patients being vaccinated with all of the boosters and all of the vaccines, and having 100% of our staff and now using Paxlovid is just the bottom line, is the outcome of that. We don't really have anybody who is getting really sick from COVID. That's just the bottom line. We would definitely see that this is manageable now. We can manage this. We know COVID is going to be with us, and it's not spreading as much as well. We noticed that because of the less symptoms, less respiratory, symptoms, that allowing the spread, and that's also making it less spreadable and better contained. So using the treatment has been, we think that it's preventing people going to the hospitals for sure.
Excellent. And then how does that impact your facility's quality metrics, do you think?
Well, I think definitely rehospitalizations is becoming one big quality measures that we rated by everyone with, and that's helping. I think having people not being immobilized and isolated for longer than, sometimes they are tested negative by day 7 or 8 now. We don't have to wait for 14 days for somebody to stay in their room because they're still sick. So that creates more skin issues, that creates falls, that creates depression, isolation, use of psychoactive medications. These people already come to us with a lot of other disabilities. That this is just making them very much more immobile and create new issues that affect our quality measures at the end of the day. But with going through the disease so much easier and lighter symptoms is really preventing them from impacting our quality measures as well.
Thank you very, very much for sharing kind of like the bottom line that how it affects your skilled nursing facilities quality metrics as well. The next question that we have goes to Dr. Ricky Trussell or David. What is the test to treat initiative? And does this also apply to skilled nursing facility residents? How about their staff or maybe family members that show up?
That's a great question. Let me get to my slide. So the test to treat initiative was an initiative that was put through with the Biden-Harris administration back in March of 2022. And it's a nationwide program aimed at providing individuals with quick and easy way to access free life-saving treatment for COVID-19, these oral antivirals that we know about. And under this initiative, individuals can get tested, receive a prescription for oral antivirals, and when appropriate, have their prescription filled at all one location. So when it comes to these skilled nursing facilities, staff, family members, they would just have to get those testing, whether it be a PCR or even an at-home testing. If they're shown as positive of any sort, they are eligible to get these prescriptions written by a authorized healthcare provider, which they could be like, nurse practice, PAs, physicians, and also pharmacists as well that can write for these prescriptions and then prescribe them for those that are qualified for it.
Thank you very much. Next question that I have here, it goes to Dr. Jason Rusk here. How are these packaged?
Sure. So we've got I've got some slides for that as well. I can show you what they look like. Let's see. I can't remember which one I added first. I think it's the Paxlovid.
Okay. Let me get that up for you.
All right. Because yeah, that'd be much easier to show, I think. There we go. So the Paxlovid packaging. So it comes in a box and it comes with these preset blisters like this. You know, your experience may vary because they are still tweaking these packagings as they move along here. However, what we see here is you've got the AM and the PM dose. This is the standard dose package. So your morning dose is 300 milligrams total of nirmatrelvir and 100 milligrams of ritonavir. And so that's 2 tablets of the nirmatrelvir and then 1 tab of the ritonavir. And then it's basically set for a morning and evening dose. Because they do have the dose reduction when your renal function is lower. If you go to the next slide, I'll show you what the dose reductions look like. So these have been a bit of a mess, and they're getting better. Initially, they just came with a sticker, and the pharmacist would punch out 2 tabs because your dose really only changes from 300 milligrams nirmatrelvir to 150 milligrams nirmatrelvir. The ritonavir component doesn't change. So initially, pharmacists would just punch out a dose from each time of day, and they would slap that sticker over it saying that this has been adjusted at the pharmacy. This was confusing to people. It was easy to miss. The ISMP, the Institute for Safe Medication Practices, had a big write-up about how disastrous it could be. Shortly after, they started actually packaging and sending out Paxlovid as a renal package as well. So you see that blister card there, which has 1 tablet intentionally removed by the factory. So it's gotten a little simpler. You can just order that renal dose packaging at the same time you're ordering your regular and dispense either one that you need. You still can modify the regular one if you needed to in a pinch if you don't have that renal one on hand. And then the molnupiravir is on the next slide. So this one, I've got 2 different bottles to show. Lagevrio, again, the brand name that they are now packaging it as. It's coming as a bottle. It's not pre-packaged. And it comes as a 40 count bottle, which is enough for 1 course of therapy. As far as I can see on this bottle and in the fact sheet, there are no restrictions regarding dispensing in this original container, and that's noted on the branded product. If you go to the next slide, what most pharmacies currently have, because our molnupiravir stock moves so slow, we haven't gotten any Lagevrio. It does say it's still a 40 count container. It does say to dispense an original container. Because of that, you may see pharmacies who do not want to put it into a bingo card. So even at a facility, you may get this as an intact bottle. There's always going to be controversy and disagreement on that. However, the molnupiravir bottle does fairly clearly state, do not repackage this. So that's the only precaution there.
Perfect. And can any of these medications be crushed or administered through feeding tubes?
I've got some slides on that, and I'll try to keep this quick, but they're a bit controversial as well. So the Lagevrio, the EUA fact sheet says to swallow it whole, do not open, break, or crush the capsule. There is unpublished information from the manufacturer that they will share with you if you contact them, that it has pharmacokinetics that are really unaltered from opening, sprinkling onto soft food, or administering via feeding tube. There's also a compound recipe available online at uspharmacist.com. Those links are at the bottom of that slide. And if you go to the next slide, I think I have a little more info. So I've got 2 slides. I won't read you the entire directions, but this actually came to me from the manufacturer. They sent me this oral suspension dose preparation for molnupiravir. So people can read this, at their leisure, but it's basically explaining how you would open up these, transferring it into something very similar to how you would prepare other medications for a crushed administration or an opened administration. So there's one more slide just finishing up that process. So this one, even though the EUA fact sheet does say, administer this whole, and when we're looking at EUA, we have less permissions off-label. There is fairly robust data that this is safe to open or administer via feeding tube. If you go to the next slide, the Paxlovid becomes a bit more controversial. The EUA fact sheet, again, states very clearly, do not chew, break, or crush this tablet. When I contacted the manufacturer, I received back in writing them saying, we do not want to say anything other than what you read in the fact sheet. So I shared that little paragraph as well. If you go to the next slide here, if you start Googling around on this one, you will find a lot of opinions. One of the most prominent ones is this BC, I believe that's British Columbia, COVID Therapeutics Committee, who has like a 3-page paper saying, we think you can split and crush Paxlovid and administer via feeding tube. They give a long explanation as to why. They reference other studies with the 2 components individually. And so they're saying, yes, go ahead and do it. And if you go to the next slide, you've got more counterpoints. Our COVID-19 treatment guidelines, which I refer to a lot, I've seen them referenced in these slides as well. This is our NIH, the government COVID treatment guidelines. They do now state that some data indicate the tablets can be split or crushed as necessary. And I thought, wow, they've got data. So I looked at their reference and it just went back to that BC COVID Therapeutics paper once again. So if you go one more slide up, this is a list I'd actually built for myself because I just couldn't keep everything straight. So on the ProCrush side, you have that BC COVID Therapeutics Committee, and then you have the NIH COVID-19 treatment guidelines stating maybe it's okay because of the BC COVID Therapeutics Committee. On the anti-crush side, you have the fact sheet saying don't do this. They have that warning in 3 separate places. There was a site that had a long write-up theorizing that warning may come from the dispersion technology. I want to be clear that the dispersion technology is not clear in the fact sheet. So they're believing it may be because it's this nanocrystal or amorphous solid dispersion technology, which doesn't appear as extended release, but does have altered absorption if it's crushed. The ritonavir individual package insert states not to crush. It is on the ISMP do not crush list. Australia has a don't rush to crush 4th edition that recommends against cutting, crushing, stating that ritonavir may cause numbness or tingling of the mouth. And finally, we do have other oral and IV options available. So my head usually swirls on this one. I'm sure there are facilities who crush this and put it through a tube, and you've probably not seen anything terrible happen because, as we've also discussed, most people are very well vaccinated. So oftentimes I think it's going to be hard to tell whether the Paxlovid was slightly less effective or not. But in my opinion, I would say if you have to cut or crush, I would choose a different agent.
Yeah, thank you very much for that information, Dr. Russ, because this is a very common situation within our long-term care facilities when people can't swallow their pills whole, for example. So very good. We're over time. Is that right, Lyndon? Yeah, by 3 minutes. I first want to thank all the panelists for participating in this event. We had several more questions that we were unable to get to, but we will release that information out probably in a document. And so again, my heartfelt thanks to the panelists for agreeing to participate in this. And thank you for the audience as well for coming in with their questions.
Thank you so much, Dr. Ong. You will see future information coming from us as follow-up from this roundtable. Thank you again. Enjoy the rest of your day.